It's a pleasure being with you virtually today to talk about the recent developments in the management of triple-negative breast cancer. Please note my disclosures. One of the challenges with triple-negative breast cancer for many years has been that it isn't one defined subtype. And in fact, it's probably a mixed bag of different subgroups of breast cancer that are lumped together based on the fact that they don't have estrogen receptors and don't have HER2 receptors. There have been numerous attempts to classify triple-negative breast cancer. In the recent years, we have focused a little bit on gene expression subtyping of triple-negative breast cancer, going away from the old pathological classifications, for example, metaplastic or other subgroups. But even those gene expression subtypes haven't been very helpful. For example, what I share here is the Baylor classification, which defines 4 subgroups, 2 basal subgroups, 1 immune activated, 1 immune suppressed, a mesenchymal subgroup, a luminal AR subgroups. There are different classifications who come to relatively similar results, but some of them with 6 subgroups, some of them with fewer. The bottom line for me is those subgroups are very unlikely to play a relevant role going forward. In fact, we are probably more going to focus on therapeutic strategies and then the associated group of patients who may derive a benefit. So, for example, for immune therapy at the moment, in the current way we give immune therapy, it's for patients who are PD-L1 positive. For PARP inhibitors, and again, at the moment, it's for patients with BRCA germline mutations. For antibody drug conjugates, we can again define the possible target population and whether that is JOP2, whether it's HER2, for example, HER2 low expressing patients, HER3 LIV1, and there's a number of ADCs coming through. And really interesting in the development of these antibody drug conjugates is that they do no longer need to be around oncogenic drivers, but can just target any surface protein. AKT inhibitors, we will see phase 3 data at the end of probably next year. Phase 3 trials are completed, encouraging phase 2 data, but we have to see how it pans out in phase 3. And then we've got that group of patients who are androgen receptor positive. Now, 2 important points to make. One is these subgroups defined by therapeutic targets and on patients are overlapping. So you can have patients that are PD-L1 positive and have a BRCA germline mutation, for example. And also these subgroups are not very well aligned with the gene expression subgroups or any of the pathological subgroups. So in the future, we are likely to say this is a patient who has PD-L1 positive tumor, SP1 for 2-3%, BRCA germline mutation, JOP2 medium, HER2 low, HER3 positive, and androgen receptor positive. It allows the oncologist to select the right treatment options. If you start briefly with early triple-negative breast cancer, in the past, we started patients with primary surgery followed by adjuvant chemo, but we're increasingly switching this, and we should switch this to preoperative chemotherapy followed by surgery, even in patients with operable disease. And there are 2 main reasons why we should do this. One is we facilitate effective downstaging, and that facilitates less invasive surgery, especially when it comes to the management of the axilla. But secondly, and more importantly, we can divide patients into 2 groups, a group with a fantastic response and fantastic outlook called patients with a path-CR, complete disappearance of all cancer, and a group of patients who have residual disease, who have a relatively high risk of recurrence. And that is important to acknowledge because it's not just that we can divide patients into those 2 groups. We've also learned that we can adjust that risk. In patients who have residual disease, we can subsequently improve their outcome. Now, the 2 questions really resulting from this. The first one is, can we increase the response to neoadjuvant chemotherapy? And this is really around the role of platinum in this setting. Now, without platinum, anthracyclines, taxanes, your path-CR rate is around 35%. There's a number of randomized trials that shows if we add platinum in, we get to around 53 to 58% path-CR rate, so substantially higher. The reason why it until now hasn't been standard in all countries, but increasingly is, and hasn't been in all guidelines, is because the long-term follow-up data weren't there. A German study showed a hazard ratio of 0.56, a substantial benefit. But a small American study showed a hazard ratio of 0.84, 5% numerical difference, but not significant. But most recently, we had data from the Brightness trial, which showed very much in keeping with the German study, hazard ratio of 0.57, more than 10% difference in EFS. And I think that should hopefully now more establish platinum as an essential part of neoadjuvant therapy in the majority of patients. The second question from the neoadjuvant treatment strategies: can we improve cure rates in patients who have residual disease? And the answer is clearly yes. And we know, for example, if we add in capecitabine as per CREATE-X trial, we can substantially improve survival with a hazard ratio of 0.52. And more recently, in the Olympia AD study, in patients with BRCA germline mutations, we can again, in patients who have residual disease or also had high-risk adjuvant disease, we can reduce substantially the recurrences and improve recurrence-free survival with a hazard ratio of 0.58 by giving olaparib for 1 year. The biggest development probably has been and is at the moment is immune therapy in stage 2 and stage 3 triple-negative breast cancer, and that's based on 2 phase 3 trials, one KEYNOTE-522, which used a very intensive chemotherapy regimen, paclitaxel carboplatin for 12 weeks, followed by AC or EC, all the way through with pembrolizumab, and then continuation in the adjuvant setting with dual endpoints, PathCI and event-free survival. And a smaller study in PASSION-031, which had platinum-free, so suboptimal chemotherapy, with paclitaxel followed by AC, all the way through with atezolizumab, only looking at PathCR rates. Both trials are positive. Both trials are positive for PathCR, having about a 15 roughly % increase in the PathCR rate, obviously on a higher level starting with platinum-based chemotherapy compared to the platinum-free chemotherapy in PASSION-031. But we've also now seen a long-term benefit in terms of event-free survival, substantially improving event-free survival with the addition of pembrolizumab, hazard ratio 0.63, 16% with pembrolizumab of patients had an event compared to 24% of patients who did not get immune therapy. So that's a big step forward. And if you look at the benefit across different subgroups, for example, by nodal status, where we initially thought node-negative patients may not derive quite as much benefit in terms of PathCR. But if you look at the event-free survival data presented in San Antonio, hazard ratio 0.58 for node-negative patients, 0.65 for node-positive patients. So clearly a benefit consistent across all subgroups. Interestingly enough, the same applies for PD-L1 positivity or negativity, where I saw that patients who have PD-L1 positive disease derive a similar benefit to patients who have a PD-L1 negative tumor, and that's both for PathCR and for event-free survival. And an interesting and sort of discussion, a sparking analysis was pre-planned in KEYNOTE-522, and they looked at the outcome of patients who had a PathCR or who didn't achieve a PathCR, and then separated by immune therapy or not. Well, there are 2 things you can see from this slide. Apart from patients who have a PathCR do fantastically well, but they do a little bit better still if they have immune therapy, about 2% difference at this point in time, event-free survival rate, has a ratio of 0.7. But the second point, equally important, if you look at patients who have residual disease, they have about an 11% difference in event-free survival rates with the addition of pembrolizumab. So my conclusions here are a presence of PathCR benefit is obviously predictive of long-term outcome, but patients may still benefit from immune therapy even if they do not achieve a PathCR benefit, and that's really important for further drug development strategies. Where are we heading in early disease? We haven't spoken much about stage 1 disease, and that's where we're looking into de-escalation strategies. We're setting up trials with chemo-free combinations, for example, ADCs with or without immune therapy, where we only give chemotherapy in non-PathCR patients. In stage 2 and 3 disease, the new standard is chemotherapy and immune therapy, and we will do a bit of fine-tuning, role of platinum, identify optimal responders, but most importantly, decide whether patients really all need adjuvant immune therapy, which they should get at the moment, even if they have a PathCR, and what to do with patients with residual disease, whether to add in chemotherapy to immune therapy, whether to switch to ADCs, or just to continue with the immune therapy alone. Now, if you move to metastatic disease, and this is only 3-4 years ago, where the management was very limited in these patients. First-line setting was taxanes or platinum combinations. In a second-line setting, often eribulin already, and sometimes in the third-line setting, we are already running out of treatment options. And only 4 years ago, the overall survival was around 12 to 15 months in this subgroup. And as we said before, this was really down to the heterogeneity of the disease and us treating all patients in the same way, but with what we shared before, with the recognition that we should tailor therapeutic strategies based on the target population. We have made massive progress. The first progress was in patients with BRCA germline mutations, where 2 randomized studies showed a substantial benefit for a PARP inhibitor over standard chemotherapy in a first-line, second-line, and third-line setting with a hazard ratio of around 0.54, 0.58. Now, what is important to mention is the response rate. They were very impressive, substantially higher with PARP inhibitors. But if you look at the response rates to platinum in a phase 3 trial, TND was also in a similar range of 68%. And the other thing that's not on the slide is that patients did not derive a clear survival benefit. But also, and that's important for sequencing strategies, patients have a relatively high response rate, even in a second or third-line setting, which is important when we come to immune therapy and treatment sequences. We're also getting early data, small numbers of patients, that PARP inhibitors could work in patients with other germline mutations that are not BRCA1 or 2, and in particular here with PALB2 mutations, whereas patients with the CHEK2 didn't seem to be responding. And we also have data that patients with somatic, so tumor mutations, BRCA1 or 2, may also derive a benefit. These are early data and need to have further confirmation in other studies. Immune therapy, as we said, in early disease is really a clear plays a clear role in metastatic disease. And it's always important to look at the whole interaction of the immune system and the tumors, as demonstrated here in the cancer immunity cycle, which starts with release of cancer cell antigens by, for example, chemotherapy, radiotherapy, or any other effective therapy. And these cells need to be then taken up in antigen-presenting cells and lead to priming activation, trafficking back of the cells to the tumor, where they recognize the cancer cells and can essentially kill them. Now, we know immune checkpoint inhibitors work predominantly in the final phase, but we're also now increasingly learning that we have different subtypes of triple-negative breast cancer based on the immune biology. We have some patients who have hardly any immunity, immune deserts, and there we need to first boost the immunity before we give immune checkpoint inhibitors. We have other patients where the immune cells are there but can't really get into the cancer. And then we have patients who have already inflamed cells, but it just needs a little nudge, where immune therapy alone may even give a good benefit. For most of the patients, we will require a combination strategy. And the number one combination partner at the moment is chemotherapy, because it can release cancer cell antigens. It can reduce the activity of the inhibitory regulatory T cells and increase PD-L1 and CD8 infiltration. Now, we've had 2 successful randomized phase 3 trials, very similar design in PASSION-130 on the left, KEYNOTE-355 on the right, use different checkpoint inhibitors, different chemotherapy backbones, nab-paclitaxel alone within PASSION-130, nab-paclitaxel or conventional paclitaxel or gem-carbo with KEYNOTE-355. And KEYNOTE-355 also allowed slightly earlier disease recurrence and with only 6 months disease-free interval because of the inclusion of platinum-based chemotherapy. But both trials show remarkably consistent results, and we are both positive for progression-free survival, but most importantly for overall survival. If you look at PASSION-130, we see a hazard ratio of 0.67 with atezolizumab, KEYNOTE-355 hazard ratio of 0.73 with pembrolizumab, both clear improvement in overall survival. But important to recognize, this improvement is only seen in patients with PD-L1 positive tumors, and we'll get back to that in a second. Now, how important is the chemotherapy backbone in metastatic triple-negative breast cancer? In the KEYNOTE-355 trials, we saw relatively comparable outcome between patients who received nab-paclitaxel, paclitaxel, or gem-carbo. But you may be aware of a trial in PASSION-131 which was negative and used paclitaxel as a backbone. But there are other challenges with these trials, which I'm happy to discuss later on. Ultimately, the backbone probably doesn't play such a big role, but there's still a question mark behind paclitaxel in this context. We've done a lot of work in the last 12 to 18 months on who benefits from immune therapy in metastatic triple-negative breast cancer. Now, there's still some confusion out there around PD-L1 testing. There are two assays we use at the moment in the clinic. One is called SP142, and the other one is called 2-C3. 2-C3 is usually assessed with the CPS score, the combined pathology score, and there are different cutoffs, and it's important to recognize how relevant those cutoffs are. If you look at the 2-C3 assay with a cutoff of 1, you see 80% of patients are positive. If you look at the SP142 assay with a cutoff of 1%, it's only 40% positive, and there's a subgroup of the CPS1 patients. If you take the CPS score, so 2-C3 assay with a cutoff of 10, it's again only about 40% being positive. And there's only about 75% overlap between those two assays. Now, the benefit of immune therapy was seen in either CPS 10 or higher, or SP142 1% or higher. And you can see, as those two assays are not 100% overlapping, it may make sense in individual patients to run both assays if you have access to both drugs. We also tried to work out whether immune or molecular subtypes can help us identify patients better for immune therapy. Again, looking at PD-L1 scoring, pretty black and white, who benefits, who doesn't benefit. And if you look at the immune phenotypes, immune excluded, immune inflamed, immune desert, you see in PD-L1 positive patients, we have all subgroups represented. If you look at the molecular subtypes, basal activated, basal immune suppressed, mesenchymal luminal layer, again, you have all subgroups represented in patients who have PD-L1 positive tumors. Now, of course, the inflamed subtypes are less commonly seen in PD-L1 negative tumors, but are still present there. And we looked at PD-L1 positivity across the different subgroups, and you can see there isn't a subgroup where you say you shouldn't do PD-L1 testing, even in patients with immune deserts, even in patients with immune suppressed subgroups. Still, a third of patients, or 8% of immune deserts, are PD-L1 positive and should be considered for immune therapy. The second big area of development in TNBC, and actually in breast cancer in general, is the introduction of new antibody drug conjugates. And we had to learn that ADCs can be very different from each other. And that's not just down to the target they're binding, but also there's a lot of work going into the linker biology, how stable it is, how many molecules get glued to the antibody, where it gets broken up, the linker, in the periphery or tumor selective. And there's a lot of work going into what's the optimal payload, the optimal warhead to kill those cancer cells. So in the past, we always thought the ADC binds to the cells, gets internalized, and then the drug diffuses back into the cell where it destroys the cell. We've now learned there's a really important effect called the bystander effect. And that means can be through two mechanisms. One is that the payload gets broken off the ADC even before the molecule gets internalized, but also that the cytotoxic drugs can diffuse out of the cells and therefore kill surrounding cells as well. And it's one of the explanations why those new ADCs are so much more effective. If you look at the different ADCs explored in triple-negative breast cancer, a lot of them have shown very promising results. LIV-1, responses of 25%. We'll talk about sacituzumab in a second. We have Dato-DXd, again in a second, targeting CHOP2. We have HER2 targeting, HER3 targeting ADCs. Now, if we focus on sacituzumab, CHOP2 targeting ADC, what does CHOP2? It's not that relevant, as I said earlier before, but it is highly expressed on most triple-negative breast cancer, and therefore an excellent target. Then the phase 3 trial ASCENT in patients who failed 2 lines of therapy. One of them could have been in the primary setting. Sacituzumab was compared with treatment of physician's choice. Majority of patients received eribulin as that. We see a substantial benefit in progression-free survival, almost 3 times as high, hazard ratio of 0.41. Overall survival doubled, 12 versus 6 months, and this is in heavily pretreated patients. But really, for me, the most exciting result is probably the objective response. Now, in patients with third, fourth line triple negative breast cancer, nothing really works. Chemotherapy, 5%, as you can see. But the objective responses here were 35%, substantial benefit, especially in patients with symptomatic disease. Having got biomarkers here, we looked at CHOP2 expression. Majority of patients have a medium or high expression, and all patients seem to be, even with low expression, do better compared to standard chemotherapy here in terms of response, but also in terms of overall survival. So no need at this point in time to select patients for sacituzumab therapy. We also had at San Antonio really interesting data on a different ADC targeting CHOP2 called Dato-DXd, that uses the same platform as T-DXd, which you may know from HER2-positive disease. And again, similarly encouraging results, response at around 50%. Two factors to highlight. You can see patients in orange in this waterfall plot who had prior sacituzumab therapy. Well, that shows that some patients will respond even if you already had an ADC targeting the same target. You see in yellow some patients who had prior a different ADC targeting another protein, but using the same payload. And again, one of those patients still responded. And that really highlights the fact that the resistance may be either driven by target or by payload. And we will have to work on very carefully how we sequence those different molecules. We also have a new subtype emerging, and that's a therapeutic, not a clinical subtype called HER2 low. As you're all aware, in the past, we defined HER2 positivity based on the benefit of trastuzumab therapy, 3+ or 2+ish amplified, whereas patients without that did not benefit from trastuzumab therapy. Now, with T-DXd, with other drugs, we have now seen in patients who are HER2 low, non-amplified, 1+ or 2+, that they may benefit from T-DXd, an ADC targeting HER2 with a response rate of 37%. And that in triple-negative breast cancer is still 1 in 3 patients. It may even be seen in patients who are, on paper at least, HER2 zero, HER2 completely negative. They may benefit, but this could just be between HER2 changing relatively quickly between different biopsies, but also different sites. So if a new therapeutic but not biological subtype, because HER2 clearly isn't the oncogenic driver in HER2 low, where we'll see phase 3 data, hopefully in the not too distant future with ADCs. We've also intriguing data of combinations with ADCs and immune therapy here for T-DXd, again in HER2 low, and immune checkpoint inhibitors. And if you look at the characteristic, most patients HER2 1+, most patients PD-1 negative, still 2 out of 3 patients responded to this therapy. There's lots to expect in the months to come. So this is where we stand now with the management of triple-negative breast cancer. In the primary disease setting, we have clear addition, new standards, chemotherapy and immune therapy in stage 2 and 3 disease, addition of olaparib either to the adjuvant therapy or in the patients with residual disease and patients with germline mutations, capecitabine in patients with residual disease, and obviously immune therapy in the adjuvant setting in stage 2 or 3 disease. In the metastatic setting, standard of care, immune therapy and chemotherapy in PD-1 positive patients, PARP inhibitors in patients with BRCA germline mutations. Other patients will receive just chemotherapy at the moment alone or in combination with bevacizumab. In a second-line setting, we have sacituzumab as a new standard emerging in patients with early disease recurrence, and clearly a new standard of care in third-line setting. The questions that are coming up now, we can possibly discuss, is really what is the role of immune therapy, post-immune therapy in early disease setting? We need to do some work on this. What's the role of different ADC immune therapy combinations, and how do we best sequence different ADCs with different targets? We also will learn a bit more about DNA damaging repair targeting drugs, whether they're new agents coming through, but also whether we can widen the indication. And we expect phase 3 data from AKT inhibitors. So we are not at the end of the development of TNBC, but it is clearly getting better and better what we can offer our patients. Thank you very much.
So thank you very much, Dr. Schmid. Indeed, it was a fantastic talk and a lot of learning. So I have few questions, and there are actually plenty, but in the interest of time, I will ask few. So the armamentarium's really widened in triple negative as well as an early stage and metastatic both, which is a good news. But there is a dilemma in caregivers. So the first question which I received is that if a patient is, BRCA positive as well as PD-L1 positive, how do you sequence, therapies and why?
Yeah, it's again, we haven't got clear data, but what I would say is immune therapy, we clearly have a survival benefit, and we have data that it works best in the first line setting. If you look at single agent immune therapy response, first line PD-1 positive 25%, second, third line only 5%. So the activity drops in later lines, possibly because of exhaustion of the immune cells or more immune suppressive effects. So you have a survival benefit you possibly jeopardize if you give the treatment too late. With PARP inhibitors, we haven't got a clear survival benefit, but we have impressive activity in first, second, and third line setting, especially when it comes to response rates. And even in the third line setting, response rates are still around 50%. So I would say you have one treatment that where you may lose some of the efficacy, the other you may not lose quite as much. Therefore, I personally would start with immune therapy and then offer patients PARP inhibitors subsequently. But of course, it's not unreasonable to do it the other way around as well.
Sure. Also, a very interesting data that, although PAT-CR is a good surrogate marker, but even if there is no PAT-CR immunotherapy, with immunotherapy, we can, enhance the survival. So is the biology per se becomes less important in the immunotherapy era, and we can actually, awaken these tumor immune cells to get much more benefit? Your thoughts?
So clearly the pathological response remains the critical the predictor of long-term outcome. But you can still derive a benefit from a therapy if you don't achieve PATH-CR. Now, there are some theories that this may just be through more substantial reduction of the tumor burden, and we will do some RCB analysis in this context. But it could also be that the immune therapy fundamentally changes the biology of the disease. And therefore, if you have residual disease, you still may have a better outlook, which is an aspect I believe in. So the dichotomy still remains that you have patients who do really well and patients who do less well. But I think in terms of drug development, it is important to recognize that you may see a benefit in patients, even if you don't see a benefit in terms of PATH-CR rates.
Absolutely. Also, the same regard about the when we are not achieving a PAT-CR, then there are options like capecitabine, platinum, PARP inhibitors, and immunotherapy. All. So where you see how to move, what looks most promising, what combination we can think in future.
So I personally would give platinum prior to surgery in the majority of patients. And we saw data last year comparing platinum with capecitabine in a residual disease setting where there wasn't really a difference in that setting. If patients who had optimal neoadjuvant therapy, depending on where you are and whether you have immune therapy available, whether it's with or without immune therapy, if they have residual disease, now let's focus on KINOT 5 to 2 patients who had immune therapy, platinum, taxanes, and anthracyclines and have residual disease. It's not quite clear what we should do. And in fact, we are arranging at the moment a global consensus with ESMO and ASCO on because we won't have data for the next 3 to 5 years. And in those and it's reasonable to just continue with immune therapy, knowing those patients do substantially better. But the question is, should we add in capecitabine? Or should we give capecitabine instead of immune therapy? And no one can answer that. From a safety point of view, we can combine capecitabine and immune therapy safely. We've seen this in colorectal cancer studies, but we obviously don't know whether there's an added benefit. So for the non-BRCA germline mutant patients, that needs to be a consensus. And I think at the moment, all 3 options are reasonable on an individual basis. I have a personal bias towards one of those options, but that's a different discussion. If you look at patients with BRCA germline mutations, I would very clearly consider PARP inhibitor in that setting because I think those data are strong And so if a patient has residual disease after chemo 5-2 protocol, has a BRCA mutation, I would offer a olaparib in this setting. Where the development is going in this setting is clearly ADCs. We have fantastic activity, and there are studies ongoing, such as the Saskia study that looks at patients with residual disease at sacituzumab versus standard of care. And I would expect ADCs to do better. If you look at the difference in response rates in the metastatic setting, 35 versus 5%. And what we essentially have to achieve here is a response against the micrometastatic disease. I am confident that ADCs may play a role in this post-neoadjuvant setting, and they're all moving in the sacituzumab data DXd. I would hope that more ADCs will be explored in this setting.
Right. So last but not the least, the apparent difference between Impassion 130 and 131. So your expert comments on that. Is this difference real or apparent, or what is the reason? What is the most important factors to be considered?
So the trial is Impassion 131 on paper has a very similar design to Impassion 130, but the difference is essentially in 3 points. The first point is use paclitaxel rather than nab-paclitaxel, and patients received steroids right at the beginning before they even had the first dose of immune therapy. The trial was 2-to-1 randomized, and the trial is smaller with around 600 patients, whereas Impassion 130 was nearly 900 patients. Now, that means the control arm is getting very small. And the primary endpoint was progression-free survival, not dual endpoints. So the control arm in PD-L1 positive patients is only about 100 patients. Now, if you look at the overall survival of patients in the control arm, paclitaxel alone was 28 months. We have never achieved 28 months with paclitaxel alone in any setting. So clearly, there's some unusual causes in here, because that's not what you normally see. So this is maybe down to unfortunate patient selection, that patients, we know how heterogeneous triple negative breast cancer is. We know that some patients unfortunately pass away within 6 months and other patients live for 5 years. And for whatever reason, there seems to be that the control arm in PD-L1 positive patients is doing much better than any other treatment we have ever seen in this setting. And that has shifted the results. Now, that control arm was more susceptible because it's a smaller study and it's 2-to-1 randomized. And that's why it's only about 100 patients, where that control arm was substantially larger in Impassion 130. So it's also interesting if you look at the shape of the curves. In the first 6 months, they are practically identical, and then they separate. And if you look at the hazard ratio, it is around 0.8 in the investigator assessment for PFS at a time when people knew the Impassion 130 data, where you have that assessment. If you look at the central review, which was published in the Annals of Oncology, the hazard ratio drops to, I think, 0.73 and is therefore not far off from what we saw with 0.6 a bit in Impassion 130. So I think there may be an element of reporting. Central review clearly gives a different reading here than investigator review in a study where we know that immune therapy is better already because the other data were available. And clearly selection was a challenge in patients in the control group with PD-L1 positive patients. So those can be reasons why we have different trial results. But you could also say it may just be paclitaxel and steroids. But I'm not buying this 100% because we didn't see that difference in Keynote 355. And we see a substantial benefit in the neoadjuvant setting with conventional paclitaxel. So why would it be, this can't be a pembrolizumab versus a atezolizumab thing, in my opinion. So if it's down to steroids and paclitaxel, we should have seen it with all checkpoint inhibitors. But we haven't got the definitive proof of what I'm saying. Therefore, if you have the choice between nab-paclitaxel and paclitaxel, you take a lower risk with nab-paclitaxel because all studies are positive there. But from a scientific point of view, I think there are other factors that contributed to those different results.
So very nicely summarizing the facts, and there are plenty of questions, as I said, but in the interest of time, we have to, we have to stop here. Thank you very much, Dr. Schmid. Indeed, it was a fantastic session. Thank you.
Thank you. Pleasure being with you.